Uh, it's my pleasure to invite Professor Sandeep Grover, and you're all reading on this, but let me share with you a very happy news. Just 2 days ago, Professor Grover has been elected as the next president of Indian Association of Geriatric Mental Health. So let's give him a big hand. Shalini, it happened. Name hands. Okay. Uh, well, congratulations, Professor Grover, once again from all of us for assuming this important position. Sandeep, as he is known to me, is a very dear friend and a very long associate. I think I have worked most of my career with him among all the people who came with whom I got associated. I tell you that by far he is the most prolific original, the person who publishes the original research. He is very prolific in that. And as you can see, he has nearly 750 publications to his credit. And these are all in very reputed journals. And I think, if can be corrected by anybody, he is probably the man who has the largest number of original research publications in this country. He is also a very sought after speaker in most of the psychiatric fora and also the non-psychiatry meets where the mental health issues are discussed. And a highly, as they call, a decorated soldier. He is a very decorated academician who has received many awards, and maybe one of the very few who has been awarded thrice by the Indian Council of Medical Research, and also many other bodies, including Indian Psychiatric Society. Hardly a year passes by when he doesn't win one or the other kind of award, from the Indian Psychiatric Society. Dr. Grover is, apart from his interests in the adult clinical psychiatry, has particular aptitude for consultation liaison psychiatry, and also for the psychopharmacology, and is part of many international consortiums which have studied the clinical psychopharmacological studies in the clinical settings. Extensive experience in as an editor of so many journals. It's really a pride and privilege, as well as more than that, a pleasure for me to welcome Professor Sandeep Grover and invite him to present his exposition before us.
Thank you, sir, for the generous introduction. At the outset, I would like to thank Subodh and the whole organizing team for asking me to speak on this topic. I'll not be going much into the theoretical aspects. I'll be talking more about practical aspects of what happens in emergency. So when I'm making this talk, I do not have any conflict of interest with regard to, except for that I'm a clinician and a researcher who works in this area. And with regard to the disclosures, I'll be using certain images and tables which are available on the internet, but the copyright lies with the original authors, so copyright is not with me, except for my own publications. And my talk I am going to cover under this 5 broad headings. So let's first try to address the first question. Why talk about substance use in emergency? So when we look at the data across the world, there are 2 kinds of studies where they try to evaluate the prevalence of substance use in the whole population which is coming to the emergency, and vis-a-vis the consultations which are sought by the psychiatrist or from the psychiatrist, and where the prevalence of substance use has been looked at. So when we try to understand that, most of the data, if you look at that, regarding the generalized or the so-called universal screening, comes from the developed countries, mainly the USA. And when you try to understand this, that the data is again very, very variable across different countries, depends on the sample size and other things, but the prevalence rate on an average varies somewhere between 2 to about 11%, but there are other studies which will talk about prevalence rate varying from about 20%. This is the universal screening kind of a data which you need to understand. And when we talk about the prevalence in the people with who have been consulted by by the psychiatrist, again here we need to understand that the different screening methods have been used, the psychiatric interviews or the so-called, we have relied on the lab methods to determine the prevalence of various psychiatric disorders, and the prevalence actually varies from, let's say, 20 to about 50%. So that means every one in about 3%. Average, if you take the mean, if you look at the table, most of the studies will report prevalence rate between 30 to about 40%. So that's the kind of prevalence we are talking about in the psychiatric referrals. What is the Indian scenario now? Do we have any Indian data for this? So again, very few studies, small sample size studies are there from India, and if you look at the prevalence figures, it again varies from about 1.5 to about 35%, and this 35% is also not the referral kind of a pattern, that is the screening kind of a study which I will be discussing later on, but on an average the prevalence rate in the referrals in most of the studies across the different centers have varied from about 1.5 to about 20%. So what is our scenario? What do we see in our department in the emergency? So this study, where we focus on the data of about 4 years involving about 5,500 patients, if you look at that, substance use is about 18.5%, and the prevalence rates vary from about 16 to 21% across different years. So that's the kind of data which we have when we look at our emergency setup with regard to the prevalence of substance use referrals which we get in the emergency setting. And what are the most common kind of substances? If you see, half of them will have alcohol, another 1/3 will have the opioids, about 10% will have more than one substance. If you look at that, 10% will have more than one substance, and few will have the cannabis. So that's kind of setting the kind of the substance use prevalence which we see in our referrals which we get from the emergency setting. So when we look at the most of the studies in the emergency, they are based on actually the referrals, and they lay out data about the universal screening. So this was a study which was done quite a few years back at our setting again, where we just focus on the elderly patients, and we had screened 232 elderly patients by using the CAM, mini screen and the assist, and those who were screened positive were evaluated on ICD 10 criteria at that time. And if you can see that about again 1/3, this was the 35.3% prevalence figure which comes in there, that they had the substance use, and means although many of them, that means that although many of them have substance use, they are not referred to the psychiatry team, and about 1/5 have the so-called dual diagnosis in the emergency setting. So what we can conclude, that substance use is highly prevalent in the emergency setting. So this is what we need to be aware of, and that is where it is very, very important that we have skills to manage substance use in the emergency setting. Moving to the next question, how it is dealt with in the developed country vis-a-vis the developing countries. So this is where we need to understand that in the developing countries, most of the developed countries have methods like universal screening, doing the medical management, involving the ex-patient as providing the peer support, referral for the treatment, those who require that. Then they involve a lot of training part, that they try to sensitize and train the emergency clinicians and the nurses. So that's where how the substance use is dealt with, because we just want to avoid that many times the clinicians and the nursing staff will have a lot of stigma and negative attitude towards people coming to the emergency with substance use, and they will have associated personality disorders and everything. So it is usually suggested that they should be trained, sensitized, so that these people get adequate care. Then there are laws for that. How do you manage substance in the emergency? Then you have that this, what you need to understand, the management of substance use, that is where in the developed country is not just dependent on the psychiatrist. Now when we look at the emergency psychiatry models in the across the globe, if you again look at the developed countries, you can have psychiatrists as part of the emergency services, or there are proactive models that psychiatrists will go and screen all the patients coming to the emergency, or you have the independent psychiatric emergency model, that any patient can walk into a psychiatric emergency which is independent. And that is where then further with regard to how the psychiatrists are involved, they can be an additional personnel which is who is there in the emergency, or they are psychiatric and the medical emergency are co-located close to each other, or there is agreement that whenever the psychiatrist care is required, a psychiatrist will come in, or there is an external specialist unit. What is the Indian scenario now? So, in most of the places, the psychiatrist is on call. You don't see a psychiatrist being there in the emergency round the clock. Among the various GHPUs, ours is the only one where a psychiatrist is posted for about 12 hours in the emergency, and in NIMHANS, the psychiatry team runs a separate psychiatry emergency which tackles substance, geriatric, child, everything, and the people who are doing the DM, they are posted in the daytime, and those who are otherwise part of the emergency unit, they cover the emergency for round the clock. That's kind of models which work across the country. So, when we compare that with the developed countries, we are far behind in providing the emergency services. So, what happens if a patient with substance use comes to the emergency? Rather than be worried about screening and triaging the patient, the first struggle starts at emergency is that this is not my patient. The struggle starts there. The physician will say this is not my patient, it is your patient, and psychiatrist will say that this is a patient who has medical complications or is presenting with withdrawal or intoxication, so it's a medical emergency. You manage the patient. That's the kind of scenario which psychiatrists often face in an emergency setting. So, what do we follow in our emergency setting? The basic rule which we follow is nobody takes the patient, we will take out the patient. Okay. So, if at all patient is coming with a psychiatric emergency, or a patient with psychiatric morbidity coming with medical morbidity or with any kind of substance, if nobody takes the patient, we will take the patient. We will start managing the patient, but we have SOPs with the medical emergency team that if whenever we feel that patient needs to be under their care, we send the patient to under their care. This is what is something which as psychiatrists we need to develop those kind of services, so that the patients in the emergency are not neglected, because we are far behind the developed countries where we can work with the clinicians to sensitize them about why or how to tackle people with psychiatric emergencies or the medical or the substance use related emergency. And at the same time, if a patient who is primarily under the medicine or surgery to start with, or for that matter with orthopedics, and they plan to discharge the patient, but we feel as a psychiatry team that patient will require more observation with regard to the substance withdrawal, intoxication or a psychiatric care, we take over the patient and manage the patient. So, that is what is the message which I just want to set across to everybody, that if you are managing patient in emergency, you need a dedicated team that who understands, and you need to have a liaison with the primary medical and surgical and trauma team, that whenever the patient requires a different kind of a care, we can shift the patient from one clinician to the other. So, what we understand here, how is substance use disorders dealt with in the emergency in the developed countries versus the developing countries like ours. So, there is a huge gap in the kind of services which we are providing to the patients in the emergency, and we need to develop emergency psychiatric services across the country, so that our patients get due care in the emergency. Moving on to the next part. So, what are the common presentations of substance use disorders in emergency? This is something which we come across every day, nothing new about it. So, the basic broadly we try to understand the substance use disorders can present to the emergency with either a withdrawal, intoxication or some kind of a poisoning. Now, this poison, many times we see patients coming to the emergency with substance use, that they take alcohol, they intoxicate themselves and then take organophosphorus or something, so that their suicide attempt is that they feel that would be less painful or less traumatic to them, but that's how it occurs. So either they come with that, or sometimes people will come with something like opioid poisoning. But compared to the Western world, especially the US, opioid poisoning here we see very rarely, and whatever, if at all it comes, it's mostly managed by the medicine team, and it's only when they are close to discharge possibly they get involved us. So, how we encounter substance use besides these broad headings about intoxication, withdrawal and the poisoning? They can present with acute medical emergency, acute surgical emergency, trauma, comorbid psychiatric disorders are present as a part of suicide attempt, agitation or aggression. So, that is where the primary presentation may not be substance use, but it may be something else. But when you try to look into the history, you will find that there is an associated substance use, and rarely a patient presents with isolated substance to the emergency. So, this is what we need to understand, that when you are trying to manage substance use in the emergency, you need to know that it will be very rarely that you will see a patient only with substance. You will have other associated complications involving that. And with regard to different types of substances, what we need to see that for alcohol you will see either withdrawal or rarely you will see intoxication. For opioids, again withdrawal, intoxication, poisoning, very less frequently seen. For cannabis, you will have the induced mental disorders that is common of that you will see cannabis induced psychosis or mania, or there may be somebody who is using who is already having psychosis, starts using cannabis and he develops worsening of his primary psychiatric illness. Then for other drugs you will see something like intoxication or the withdrawal, but this may be again presenting more with medical emergency, and this requires high suspicion, high level of suspicion to consider these possibilities, especially when a patient comes with something like pneumonia or some cardiac complications, that you need to learn that to screen the patients for the substance use. So, when you are taking a history, in majority of the cases the history is obvious, but many times the history is not obvious. That is something which we need to remember, that the person who is taking alcohol or some other substances is remaining most of the time out of the house. Family members don't know how much he is taking, what he is taking, and so that is something which you need to also understand. Or when the police is bringing the patient to the emergency, again when patient is unconscious, police does not know what he was taking, what he is not taking, and that is where it becomes very, very important to suspect the substance. And similarly when somebody is brought by the co-workers. So, just to remember, what are the common presentations? So, withdrawal, intoxication and poisoning. Now, let us try to understand the basic principles of management of substance use in emergency. So, for managing substance use in emergency, you need the basic knowledge of medicine more than anything else. Maybe psychiatry or the addiction psychiatry comes later on, but first you need to know the medicine. Until you do not know the basics of managing an acute emergency, medical emergency, you will have a problem and you will often lose the patient. So, what are the 4 basic steps? We will try to understand the medical stabilization, the psychiatric stabilization, monitoring the patient and the follow up. So, when we try to understand the so called initial assessment, it can be again understood under the 4 broad headings, that is assess for the presence of substance use, treat and stabilize the acute presentation, manage the substance use disorder and have a disposition plan. Manage the substance use disorder basically means we are talking about here about the long term plan. So, how do you assess for the presence of substance use? So, basically while you are taking the history, please try to focus on certain basic aspects, like the type of substance the patient is taking, the quantity consumed, the last intake, or you should not just rely on the last intake, but recent reduction in the doses may also be very, very important. Many times the residents commit this mistake that they just focus on the last intake and they do not focus on this issue about recent changes in the doses, because a recent change also can lead to withdrawal, and that is where the problem can occur. And then past history of withdrawal in terms of DT or seizures and any possibility of fall, because this is something again very, very important, that when a person is taking alcohol, especially an elderly or somebody, any small fall, something like hitting to a wall, can lead to SDH. So, that is what we need to remember when you are evaluating a person coming to emergency with alcohol or other substances. And I think I will thank Shalini, she has covered many of these. So, if you want to use certain screening scales, you can use like CAGE, family CAGE, audit and the drug abuse screening test or assist, whatever you want to use, but usually this is not very much required. Many times the history is so obvious. And in when you are suspecting the so called covert substance use, or you do not have a clear history, you can use the breath analyzer, urine kit or screening for poisoning. This is where you need to be very, very clear when the history is not clear what you are supposed to do. And when you are doing the screening, you should be very clear which substances you are looking for and what kind of pattern. You should be knowing that for how many days the patient has been taking the substance, so that you know what is the possibility of getting it positive or negative. And the other thing is that what has been the pattern, because if somebody is taking the drugs for short duration or chronic duration, the possibility of urine kit becoming positive is different. So, that is where you need to be understanding that the importance of doing the urine screen. And at the same time, this becomes important in patients coming with medical emergencies or who are having dual diagnosis, that certain psychotropics can have reaction or can give false positive results. So always check what medications they are on, so that you know that there are no false positive urine kit tests, so that you unnecessarily also don't subject the patient to the treatment which may not be required. Then treat and stabilize the acute presentation, because this is something which is often not given much of importance. We talk about like lorazepam doses and other things, but this is something which is actually the most important aspect. So what usually we do, place the patient in a safe place, and so that what you basically need is no overstimulation and no neglect. So if the patient is out of sight, you understand that patient will be out of mind. So place the patient at such a place that the patient will get due attention, because what happens many times, if a patient is under psychiatric care and you are seeking medical consultations and you try to place the patient at a distant place, the medicine team is not reaching, and the nurse is not reaching there to give the medication to the patient. And if so, that's where it's very important that when you're placing, for example, we have different places, so we try to place people coming with substance withdrawal or intoxication either in the area, and we try to tell the primary team, the medicine team, that you manage, patient will let the patient be under your care, so that the nursing care can be provided to the patient. Our team will keep on seeing the patient. So this is very, very important. Where do you place the patient in the emergency? If the emergency is a very broad area, so don't place the patient far off from the medical team. That is something which you need to remember. Sorry. Then the next part is understanding the vital signs and the cardiopulmonary stabilization, ensuring the safety of the patient and others, treating the emergent intoxication and withdrawal, and preventing the complications. So again, immediately the residents need to understand that what is to be done, because this is something, until you don't focus on doing the cardiovascular and pulmonary stabilization of the patient, what is going to happen, that it is more likely that you are going to lose the patient. And if you depend only on the medicine team that they are going to do, they have a patient with myocardial infarction or somebody who is having called the respiratory failure, then for them this patient may not be a priority. So you need to understand that if you are working in emergency setting, you need to prioritize the patient, own the patient, and make all efforts to stabilize the patient with regard to the basic things, and you get the heart rate, blood pressure, you take the body temperature, fasting blood sugar, and whatever else is required, so that you have the basic parameters in your hand. Send the investigations, the usual investigation like hemogram, electrocardiogram, ABG, and the fasting blood sugar, random blood sugar should be in hand before you start thinking about managing, and renal function test, liver function test, and the X-ray chest. Other optional investigations, again, many times depending on the kind of substance the patient is taking and the kind of so-called hepatic decompensation you are suspecting. So ammonia level, bleeding time, clotting time, ultrasound abdomen and pelvis, triple H. If you think that patient is likely to be positive, doing a neuroimaging or the echocardiography. So again, depending on the presentations, but many times we end up doing it, and I always emphasize that no harm in getting a neuroimaging done when the patient has multiple physical comorbidities, elderly, and the slightest chance that patient would have had a fall. So they don't take a risk. We have often seen that we manage and suddenly we have forgotten to get a neuroimaging, and patient is not improving, and then we get the neuroimaging done, and then see there is a subdural hematoma, and then we run after the neurosurgery. So it's always better that you should be very careful. I am not saying that everybody should undergo neuroimaging, but you should suspect, and whenever you are suspecting, no harm in getting it done. Then getting an IV access, ensuring nutrition, thiamine for patient with alcohol withdrawal, and taking care of the bladder and bowel, because many times this is again something that our trainees are very much aware of this part, that many times when you are suspecting a patient with that alcohol withdrawal, delirium vis-a-vis HE, and tomorrow there will be a lot of conflict and everything. So right from the beginning make an effort that ammonia levels are not rising, and if the patient has constipation, immediately in liaison with the medical team, start the lactulose or rifaximin, whatever is being decided by both the teams, so that the so-called patient do not evolve into an HE. Then again, depending on the kind of comorbidities the patient may be having, so you need to be very careful about addressing the issues like harm to self, harm to others, and at the same time harm to the physical health. And the physical health can depend on the cardiac status, that arrhythmias are there, electrolyte imbalance itself can lead to a lot of cardiac complications, encephalopathy, seizures, stroke, so aspiration pneumonia, sepsis, and these all become, when I say this, I am listing this, means all this will involve how you place the patient, what do you advise the family, how to feed him, what is to be done, should he be lying down and you keep on feeding him, how much to feed, how do you feed from the Ryle's tube. So all these simple instructions become very, very important when you are dealing with the emergency setting, and this all should not be neglected. And if the patient is there for long run, and if your patient is using an IV drug, so you should also think about the thromboembolism, and if required do the deep vein thrombosis scan and other things, so that the safety of the patient's physical health is ensured. Moving on to the treatment of so-called intoxication. So what we look at in emergency setting, that intoxication part is something which we less frequently encounter, and there is a lot of overlap with the different kind of features you see with different substances, but again it can also vary from substance to substance. So you need to be very much well versed with management of intoxication. Only basic things you need to understand when you are dealing with alcohol intoxication, depending on the agitation, you actually need to avoid benzodiazepine, and antipsychotic may be the medication of choice at that time if the patient is agitated, rather than using the benzodiazepines. And again, for benzodiazepines, again if check whether the patient requires respiratory support or not, and it's only when the patient actually has benzodiazepine, let's say poisoning, that is where you may think of using flumazenil rather than only in patient coming with some amount of intoxication. So depending on the kind of benzodiazepine, how much benzodiazepine he has taken, you need to decide about using the flumazenil. Similarly, for other drugs also, you need to be understanding the various aspects, because many times patient coming to the emergency with hallucinogens, inhalants, and the other club drugs are often being managed by the medical team, and psychiatric team is not involved, or if at all the psychiatric team is called, psychiatric team will just see the patient from the perspective that whether the patient has delirium or not, and rather than going into the in depth of patient attending a rave party or something, and then he is having some respiratory or the cardiac symptom. So that is where you need to be very, very suspicious and look into those things. Usually benzodiazepine is something which may be helpful, and again for opioids, be very careful about understanding the type of opioids, because the different opioids can have different with regard to the risk when they are taken in the higher doses. So some may lead to cardiac complications, and others may lead to the neurological complications. Now, in patients with dual diagnosis, you need to understand one more thing is suspecting the various toxidromes, because many psychotropics also act on the similar receptors, and when you are using, somebody uses the club drugs and other things and in the higher doses, or just in the so-called usual doses, although then also you will see that they will develop different kind of toxidromes, and it can be sympathomimetic or anticholinergic and so on. So be very careful about that in the emergency setting. Then is the alcohol withdrawal. I will be discussing alcohol withdrawal at the end separately, so I am moving from here. And then we are talking about the other withdrawals. Again, if we try to understand different other withdrawals, again mostly except for benzodiazepine, where you substitute the benzodiazepine and you use the longer acting benzodiazepine, others mostly is the symptomatic management. And for tobacco, again you may be thinking about using the tobacco patch or the chewing gum, depending on the patient's associated medical morbidities and the physical health conditions. And similarly for the hallucinogens, cannabis and opiates, again mostly the management is substitutive, but for opiate substitution there are certain things which we need to remember, that what kind of opioid you are going to select, whether you are going to give the patient a tramadol or a buprenorphine or what else, because this is something which is very, very tricky in the emergency setting, and depending on the kind of, if you want to give buprenorphine, again do you want to give a buprenorphine patch, or you want to give a buprenorphine so-called sublingual tablet or IV. So there are issues about the availability. So at the end we end up mostly using something like tramadol. So there, when you are using tramadol, something which you need to understand, that tramadol may be coming in a fixed dose combination with paracetamol and other drugs. So remember that when you are choosing paracetamol, ensure that the patient is getting a plain tramadol rather than a combination kind of thing, because that again creates a lot of complications in the emergency setting, especially when somebody has the cardiac issues there. Similarly, the symptomatic management again remains for the club drugs. The major focus in management should be preventing the complication, which includes taking care of the electrolyte imbalance and preventing any kind of aspiration pneumonia, any kind of secondary sepsis, or any kind of renal shutdown. So this is something again you need to monitor your patient for the same. Now, there is a situation arises in the emergency with regard to the surgical clearance, that a patient is brought to the emergency and is in a trauma, that the trauma surgeon wants to take up the patient for the surgery, and that is where you need to understand what should be done. So, just as a psychiatrist, you should be clear that if you are not just instructing or not only limiting your discussion to the surgeon, but you also need to talk to the anesthetist, and you need to discuss what is the best possible alternatives. And here again you need to be having certain basic principles. If you are not very clear, for benzodiazepines, if there is a withdrawal, there is no contraindication, you can use benzodiazepine and go for the surgery. For in alcohol withdrawal, if they plan to do the surgery and you have already started something like lorazepam or diazepam, so there you can always discuss with them, can they do the surgery under propofol, and that is what we often discuss and advise, because propofol itself can take care of the withdrawal, and it actually delays the withdrawal and emergence of DT. So, that is where another issue comes in, that many times you go and see a patient has been in the trauma ward for 5-7 days and he is developing delirium, and you say that patient has developed delirium after 8 days of last intake, this cannot be DT. But remember, if he has undergone surgery in between and he has received something like tramadol, ketamine, you remember that the withdrawal has been delayed, and this is what you are seeing is actually a DT. So, this is where again it is very, very important to remember that. And similarly, when you are using tramadol, again there is a risk of serotonin syndrome, and the thing again you need to understand the kind of the opiates the patient has been taking, and if he has a dual diagnosis, SSRIs and other things which he has been taking, so you need to be very careful about that, and especially this antibiotics, that is linezolid, that is many times preferred by the physician, the surgeons while managing patients. So, linezolid is one drug which is an antibiotic which increases the risk of serotonin syndrome. So, whenever you are looking at the treatment chart, please always remember to look, if patient is getting linezolid and you want to give tramadol and SSRI, be very careful about that. Now, manage the substance use disorder. Basically, we are here talking about the long term management of the substance use disorder. So, what basically is that when a patient is in emergency, just acute management of intoxication or withdrawal is not sufficient, and you need to plan for the long term management, and some of these issues have been covered by Shalini before my talk. So, you can think about doing a motivational interviewing, brief intervention, think about the long term pharmacotherapy and referring the patient to the de-addiction center for long term management, and this is where you need to understand that. Then is the disposition plan. So, when you are referring, or when depending on the kind of the place where you are, if a patient requires an ICU care, round the clock monitoring, try to liaise with the ICU people to shift the patient to the ICU. If he has developed a medical complication, shift him to the medical ward, or there is a trauma kind of issue, you shift him to a trauma ward. And if somebody has dual diagnosis, if you think he can be managed better in the psychiatry or the de-addiction ward, you decide accordingly. But if somebody just has a primary substance use, you can think about liaising with the de-addiction team and sending him to the de-addiction facilities. Now, at the end I will discuss this part, that is the management of opioid withdrawal and alcohol withdrawal, because this is what forms about 85 to 90% of the patient which we see in the emergency. So when you are talking about the opioid withdrawal, again we need to remember that it may begin as early as 4 to 12 hours, or it may be delayed by about 24 to 48 hours, depending on the kind of opiate the patient is taking, and we all are very much aware about the typical symptoms of withdrawal. So here the basic thing what we need to remember in terms of management is that it will totally depend on the type of physical comorbidity and the severity of the comorbidity, what kind of respiratory distress the patient has, what kind of cardiac problems does the patient has, and depending on the availability of the drugs like buprenorphine, sublingual, IV-IM or the patch. So many times the IV-IM are not possible, so we end up using patch, especially in the cardiac patients, and otherwise when you are using tramadol, use the plain tramadol. With regard to use of conventional detox regimen, so if a patient has comorbid physical condition, usually we do not prefer to use a conventional withdrawal regimen, because that is where we do not want to take a risk about destabilizing the physical health further by adding clonidine or NSAIDs, because if a patient has a cardiac issues, if you are giving NSAIDs, the risk of bleeding may increase, or similarly if you are giving clonidine, the cardiac parameters may get disturbed. So wherever possible we prefer to avoid that. Now moving to the alcohol, again when we are trying to understand alcohol, again you try to understand the very basic pattern of the alcohol which the patient has been taking, for how long, what the type of alcohol, time since the last intake, and again I do not want to emphasize again that the reduction in the doses you need to consider, and any seizures. So, also focus on the issue of history of the delirium tremens in the past, seizures or the head injury, baseline cognitive functions, any history of the pancreatitis or GI bleeding, cardiac issues, and the sepsis or any metabolic disturbances which are there. Then physical examination and investigation is a must, where you cover almost everything what you need, you are suspecting that you should not miss out. So, physical examination should focus on all the aspects of the substance use. Then in terms of in differential diagnosis, some of the complications itself can be a differential diagnosis for alcohol withdrawal. That is where you need to understand, or some of these may emerge later on when the patient is going through alcohol withdrawal. So you need to be keeping that in mind and doing the consultation, liaison and management accordingly. And the basic investigations, again I have discussed this, but here prothrombin and the blood alcohol levels if required, ammonia levels, acid base balance are very important, and getting a hemogram, looking for the platelet count, because the low platelet count if patient has, although he has not gone on to DT, but some data to suggest that those who have low platelet count at the presentation are more likely to convert into DT. So, do not wait for DT to emerge, start managing the patient in the line of DT. The other investigations, again if a patient develops CSF and there is a suspicion about encephalopathy, the liaison with the neurology team for doing a CSF and other things, and MRI brain. If you are asking for an MRI brain, you should be asking specific cuts so that you can screen the patient for Wernicke's encephalopathy. You should be very clear what are you looking for. Okay, sorry. Then evaluate the severity of the alcohol withdrawal, what is the severity and what is the time frame since the last intake or reduction in the doses. And again remember that usually the alcohol withdrawal seizures emerge within 24 to 48 hours, and the DT will emerge after 2 to 3 days, but DT can emerge as long as after 7 days or maybe about 15 days also. So, that fact has to be remembered, that before you rule out DT you should be very careful about that. And the physical examination and the looking at the signs and symptoms will give you idea about the DT. The issue here is this one, that is where in emergency you end up dealing with your physician colleague, that you want to give lorazepam and they say no, patient is in HE, you cannot give lorazepam. So, you have to be very careful in so called delineating these two conditions, that HE versus the alcohol withdrawal. So, look at the reflexes, look at the so called level of activity levels and other features to be very sure that patient has alcohol withdrawal or DT, DT or the HE. And the other thing you need to understand, that if a patient has HE and is getting agitated, usually it is not that much in HE, but if these patients get agitated, what the physician is preferring. So, again they have a list of drugs, and again in that whole list of drugs propofol always is one. So, to always talk to them, if you want to sedate the patient, use propofol, so that the withdrawal, if at all it is there, it does not emerge. So, that is what they usually prefer to do that. And when you are talking about the so called alcohol withdrawal seizures, as I said, that you will see in the first 24 to 48 hours. But again issue here to remember is that many times before you see the patient would have been seen by the neurologist, and they have loaded the patient with levetiracetam and other things, and they advise to go for a long term anti-epileptics. This is where again you need to intervene, discuss, and because patients who have alcohol withdrawal delirium usually do not require long term prophylaxis with anti-epileptics for prevention of seizures. So, when you think the seizure is not related to alcohol, if the seizure is a focal seizure and it is usually occurs after 48 hours, it is unlikely to be related to alcohol and alcohol withdrawal. And if patient has a head injury and occurring all this, that is where an indication for a pharmacoprophylaxis with anti-epileptics may emerge. So, then is the issue about the Wernicke's encephalopathy, the triad, we all know that confusion, ataxia, and the ocular abnormality. So that's where the physical examination again becomes very, very handy. And again, you need to understand that confusion here is same as what you see in DT. So it is already delirium is there. One criteria is already fulfilled. So other two can only be understood once you examine your patient. Otherwise, if you don't examine your patient, you just treat the patient as DT, forgetting that patient is at a risk of Wernicke's encephalopathy. And so you need to keep that that high index of suspicion here. And to rate the severity of alcohol withdrawal, you can use the CVAS, that's the common thing which we use. And for assessment of delirium, again, you can use the different screening instrument like CAM ICU, RASH, or the other scales, and the severity can be again rated by CAM or the CAM ICU, or itself the DRS. DRS R98 can be used to assess the severity of delirium. And treatment setting, again, we end up managing most of our patient in hall C, what we understand in our PGI emergency, or hall L, but we always, our residents make a lot of effort to get the patient into a hall B, which has some amount of so-called cardiac monitoring, and that helps many of our patients. So that is something which, when you are posted in emergency setting, try to figure out that your patient gets the required cardiac and pulmonary monitoring in where the so-called physician is more involved there. Then the basic goals of treatment is to control the agitation as rapidly as possible. We decrease the risk of seizures, decrease the risk of any injury or death, minimize the complication, and prevent and treat the Wernicke's encephalopathy. This is something which we need to keep in mind. Management of delirium, all of you know that the non-pharmacological measures, here you are using benzodiazepines, and this is where the other basic measures will come in about the use of IV fluids. If a patient has dehydration, remember to take care of IV fluids, but remember, do not give glucose before the thiamine. So that's something which you again need to remember. And if a patient who is suspected to have Wernicke's encephalopathy or having withdrawal, if he has hypomagnesemia, please try to take care of that. I am not going to this pharmacotherapy about front loading and other thing. I think all of you are aware of that, because I just wanted to talk about that. But if you are working in an emergency setting, try to prefer to understand that, prefer a symptom trigger regimen than the front loading. So there are different regimens for the diazepam and the lorazepam. So don't prefer to use a front loading regimen. And if you are using this in emergency, lorazepam, again there is a lot of controversy about the lorazepam, that people say that it is only IV lorazepam, but it's not that. IV or oral can be used. And if in what our experience suggests, that actually lorazepam requires maintenance of the cold chain to a certain extent, and in most of our lorazepam which is available in our country, it is not maintained. So IV lorazepam has poor bioavailability. So if the patient is able to take oral, please use oral lorazepam. The total doses requirement decreases. And if patient still remains agitated after giving a sufficient dose of lorazepam, suppose you are crossing 30-40 milligram, adding a dose of 0.5 milligram haloperidol often helps as a second line drug, or as I have already discussed, propofol. Only you remember that in patient with cardiac heart block, that is where it may be contraindicated, and you can use haloperidol if the agitation is not getting controlled. So and for Wernicke's encephalopathy, remember to use high doses of thiamine, 500 milligram thrice daily for initial 2 to 3 days, followed by 250 milligram for next 3 days, and then reduce the doses, and never start dextrose before that. So to conclude, comprehensive management of substance use disorder in emergency requires a prompt detection, institution of appropriate supportive measures, first prevention and management of complication, use of appropriate pharmacotherapy for management of withdrawal and intoxication, and planning for long term care. Thank you.
Well, I must say both the presentations were top class presentations, very educative, and I wish we had more time for Professor Sandeep Grover to dwell upon the very practical of how to manage complications associated with the substance use disorder in a medical emergency setting, where they often land with such complications. So maybe at some other forum, a leisurely presentation would be welcome, and I would love to attend that presentation. Please do invite me as well.
Thank you, sir.
So, with these words, with the permission of our gracious host and the head of the department, Professor Basu, I think we are coming to the end of the session, but before that, it will be our joy if some questions can be asked from the presenters, and Professor Basu, if you permit a couple of questions, can
Yes,
be
please.
asked.
Yeah,
Sure.
although we are late, but then I think a few questions can be definitely taken up after this lovely session. And talking about lovely, now we have lovey.
Yeah.
Yes. Yeah. Please. Yeah, okay. Awad.
My question is, invariably, in usual practical settings, we have to physically restrain the patient. Like if it's in delirium or intoxication, once we get reduction. Patients get very agitated. So, are there any guidelines or anything to keep in mind to for guidelines to physically restrain the patient? And second question is ki, usually one condition which is very like the presentation is same as encephalitis or meningoencephalitis. So is there any guidelines to get the patient like lumbar puncture or in the anything to rule out encephalitis before giving any psychiatric medication? Thank you.
Okay, fine. Now answering the first question, we need to understand that there are the basic dictum for using physical restraints: appropriate positioning and using the restraint for shortest possible duration. These are the two basic things, and not feeding either through the Ryle's tube or orally while patient is being under restraint. These are three basic principles you need to remember: propped up position, don't restrain him for too long, and keep on checking the patient's vitals every 15 minutes when the patient is under restraint. Don't leave it to the hands of the caregivers. Everybody is happy the patient is restrained, he is not disturbing me, so let's forget about it. That's something which is common practice, so that is where you need to change. Now, regarding the encephalopathy and the psychotropics which you can give or not, again remember that encephalopathy comes in when the patient comes to the emergency with fever and is in a withdrawal kind of a state, so that is where you are confused. So everything will depend on the respiratory status and the cardiac status. If patient is requiring oxygen support and is having respiratory distress, it becomes very difficult to use benzodiazepines at that time, or to a matter using any kind of opioids at that time. So usually, if depending on the agitation, you may end up using low dose haloperidol. If the cardiac status ECG is fine, your QTC interval is acceptable, you may still use haloperidol before doing a CSF. So from that point of view, the only thing which you can use is haloperidol rather than either opioids or benzodiazepines. Yeah, you can
Okay.
Malik.
Good morning, sir. Myself, Dr. Yogendra Malik. Sir, thanks for the nice presentation. Sir, this is regarding the models of, you have mentioned the proactive model, the psychiatrist as a independent, as a part of the multidisciplinary team, or the emergency as a separate setting. Sir, we are running the emergency, psychiatric emergency as a separate setting, but we have faced lot of challenges because whenever they refer the patient, the medical or surgical team himself or herself giving the dosage of multiple doses of antipsychotics, and they refer the patient in later stage. Like when patient presented with substance use and met with an road traffic accidents, then we will confuse whether it is because of the alcohol DT or because of the blood loss or the head injury. Number one, sir, and number second, what is your the expertise or experience said at the policy level, which model is better as far as mental health hospital is concerned?
Okay. Taking the last question first, having a co-located psychiatric services with the medicine services, or as what is happening in our emergency. For example, there is ESOPD, EMOPD, trauma, all are situated close to each other, and we work through all three. So although we do not have separate psychiatric emergency, but if the only scope, if we need to improve here, would be having a separate psychiatric beds where there is a provision that you can shift the patient to surgical, trauma, neurosurgery, plastic, whenever you require and whenever they want. So that is the best way to run a psychiatric emergency. Having independent psychiatric emergency often becomes complicated if patient is having dual diagnosis or medical comorbidities. Many times we as psychiatrists are not very much competent enough to manage all medical conditions. Regarding the head injury or other things, if patient is in that time frame where you can suspect that patient the patient is likely to experience withdrawal, delirium, or is going through withdrawal, irrespective of the head injury, irrespective of the blood loss, manage in line of DT. So that should be the very clear dictum, but provided that the physical health conditions are in that level that you can use benzodiazepine. If you are not able to use benzodiazepine, that is where the whole discussion comes in with anesthesia team, neurosurgery team, hepatology team. What are they preferring, and accordingly you become part of that discussion. The first question was. Yeah.
Like NMC released the guidelines about the consultation liaison psychiatry psychosomatic rounds, but not about the emergency separate emergency settings. So which model we will follow?
So the simpler thing to understand that our department is now 60-year-old. We started our earlier we just had psychiatric emergency as on call, and we never maintained any record. We never saw it. It is only last 10 years, 12 years that we have started psychiatric emergency as our resident is there. So gradually across the country it is going to develop with time. At present, as I said, very few centers are now focusing on psychiatric emergencies as a separate kind of a subspecialty of CL. So with regard to the policy matter, I would say that we need to have a separate psychiatric emergency co-located with other emergencies. That's where I would say that is what the people should try to do that and try to improve the services accordingly.
Any other or okay, this is the last question we'll have, and then I'll have one question for Dr. Shalini also in case we have. Okay, yes please.
गुड मॉर्निंग सर, मैं पीजीआई का जो पहला बैच है ऑनलाइन एडिक्शन साइकेट्री का उसका एक स्टूडेंट हूँ. तो मैं पूरी पीजीआई टीम को थैंक्स कहना चाहता हूँ, डॉक्टर देवाशीष बसु सर को, डॉक्टर सुबोध सर को, डॉक्टर असीम सर को भी सर. थैंक यू सर. मैं अम्बाला से हूँ और मेरा लगभग 31 साल का एक्सपीरियंस है, 25 साल इमरजेंसी का है. तो मैम अब मैं एडिक्शन सेंटर्स भी देखता हूँ, वहाँ हमारे लगभग 300 बेड हैं. तो मेरा एक सवाल है आपसे कि जो ब्रीफ इंटरवेंशन करते हैं हम, तो जो अल्कोहलिक पर्सन है, पेशेंट है, उसका रीसेंट मेमोरी चला जाता है मैम. तो वो लोग उनको एडिक्शन सेंटर में 1 महीने बाद काउंसलिंग शुरू कराते हैं मैम. तो आपसे ये रिक्वेस्ट है कि जो उनकी काउंसलिंग कब से शुरू होनी चाहिए मैम, जो क्योंकि उनमें पैरानोइया भी होता है और रीसेंट मेमोरी भी उनकी लॉस हो जाती है. तो वो उनको हम समझाते हैं, वो समझते भी नहीं है मैम.
आप काफ़ी चैलेंजिंग मुद्दे के बारे में लेकर आए हैं. तो मैं थोड़ा सा और समझना चाहती हूँ कि मेमोरी लॉस का मतलब क्या था.
जैसे मैम वो सामने बैठा है,
हाँ,
सामने बैठा है, हम उससे बात कर रहे हैं और वो जैसे इधर निकल जाएगा, वो इधर कहेगा कि उसको विजुअल हेलुसिनेशन भी हो रही होते हैं साथ साथ. तो वो समझना ही नहीं चाहता. उसकी फैमिली को समझाएंगे, हम काउंसलिंग करना चाहते हैं, वो कहती तो घर की बात है, आप अपना इलाज करो.
ये जो आप कह रहे हैं विजुअल हेलुसिनेशन होता है, डिस्ट्रैक्टेड रह रहे हैं, कंफ्यूज रह रहे हैं, रिकॉल नहीं कर पा रहे हैं, ये इनफैक्ट सवाल डॉक्टर साहब के लिए होना चाहिए.
Okay, I'll answer that.
इमरजेंसी.
So that is where we need to understand that is what exactly is a description of a patient who is experiencing delirium tremens. So many times we just rely on tremors to diagnose delirium tremens and don't focus on the cognitive aspects of it. So if a patient is experiencing visual hallucination during the withdrawal phase, as getting confused, not able to focus on something, actually he should be managed for withdrawal delirium tremens. Yeah. So there the whole management which I discussed will come into place. No, once we have managed the delirium tremens properly, which usually takes about 5 days to get cleared, then patient memory will gradually be improving. He will be out of delirium, then you can start talking to them. So it is not that and at the same time, if a patient experiencing delirium also, then also you need to tell the family members and the other people involved in the care how to address a patient of delirium. So although he is distracted, he is not taking care of things, But it is very, very important that we as clinicians, as the healthcare team, reorient them, keep on telling them where they are, what is happening. So gradually when the delirium clears, they are more amenable to any kind of psychosocial intervention.
Okay, thank you very much. We wish we could continue for a longer time, but we have run out of time, and further questions I'm sure can follow over lunch also. So I must thank on behalf of Dr. Avasthi, my teacher, and of course on behalf of the entire audience, both the speakers for extremely good, very nice, complimentary, one on the public health broader scale level, the population landscape, and the other a purely, absolutely useful clinical based talk. And with this now, I think we will come to, sir, any other comments? I think we'll close this session. Thank you very much. Thank you.
Thank you very much, sir. I would request our esteemed chairpersons to kindly give souvenirs to our speakers, please.